for the invitation and the introduction, and thank you all for coming. I'm going to start off actually with some terminology, but before I actually get into that, let me start off with additional terminology, which I didn't think about. So genitourinary, which was sometimes abbreviated GU, in the cancer world, that generally refers to urologic cancers or cancers that might be dealt with surgically by a urologist. So in order of how common they are, that would be prostate cancer, bladder cancer, kidney cancer, and testis cancer would be the main four that are there. And if you want additional information, you can see it right there. That's our blog that is aimed at kind of the layperson level, although sometimes things get complicated. So now I'm going to officially start off with terminology, including the very top of this, what is urothelial cancer when you heard about bladder cancer. So urothelial carcinoma in medical jargon. So, okay. So this is a picture of internal organs, and this would include the urinary system. So urine is made in the kidney, comes down each side in this tube that's called the ureter into the bladder, and then comes out. So that would be the overall urinary system. You can see a cutout of inside the kidney where there are things that happen to kind of filter things out, and then it goes into what we call the collecting system, or what I'm going to call the urinary system. The lining of that is called the urothelium. And if we're to kind of encompass, I'm going to use some of this terminology. I put in the circle the kidneys as well as the tubes that come down the ureter. Sometimes we'll lump that into upper tracts. So you might hear me refer to, and I have a specific slide on upper tract urothelial carcinoma that is a little bit different than what happens in the bladder. The cells that line the urinary system are called urothelial cells. They have been called in the past transitional cells. So you'll hear some people like me that trained before that will slip up and say transitional cell, or TC or TCC for transitional cell carcinoma, but the correct terminology really for more than 10 years has been urothelial carcinoma. So if there's bladder cancer, it almost always is urothelial carcinoma. And anywhere in the lining is urothelial carcinoma as well. So urothelial carcinoma of the bladder would be officially the term, but usually we'll say bladder cancer because that's the most common type of bladder cancer. Something that happens in the lining of the cells called the renal pelvis, which is this is called urothelial carcinoma of the renal pelvis, and then in the tube it's called urothelial carcinoma of the ureter. So some different terminology that has to do with the cells that are there as well as anatomy. So this is what a lot of us will call a clinical states model, and this is true for a lot of different types of cancer, where most people will kind of walk in the door here, and going from smaller, less invasive tumors, hopefully not too, but including those that do develop cancer that spreads throughout the body, as we call different clinical states. So a patient that walks in the door might be in one of these different boxes. What you can see here at the top are different arrows of different sizes. The further someone is more to the left, the more likely even if they have cancer, the less likely they're going to die of cancer, because we might be able to treat that for many, many decades and keep it at bay, but other things happen. Heart attack, stroke, getting hit by a car, who knows? If someone is going to die of urothelial or bladder cancer, then it is almost always in this particular state. That's what we call the different clinical states. Within each clinical state, I'm going to go through some of the terminology at the bottom. There are different things that we do to/for the individual patient. So if someone walks in the door and we think maybe they might have bladder cancer or some urothelial carcinoma, we'll sometimes do scans. So that might include a CAT scan, also called a CT scan. Might include an ultrasound, might include an MRI. Some sort of imaging is part of often the workup. Oscopy, you'll hear about colonoscopy, so looking inside part of the body with a camera. Cystoscopy is sticking in something to look in the bladder. If we go through the bladder and start going backwards up into the tubes, up into the kidney, that's called ureteroscopy. These are the things that are to the left. And then we can also do a biopsy with that type of a camera. A transurethral resection means we're using that camera in the operating room to do our best to remove that tumor. So without a cut from the outside, going inside and doing our best to completely take out or resect that tumor. Intravesical therapy refers to us putting something into the bladder. Could be chemo, could be immunotherapy, and we'll get into that. Neoadjuvant is a term. So chemotherapy, I think, is things that you've heard about before. Neoadjuvant means that before the primary type of curative therapy, we're going to do something first. In this case, it may be chemotherapy prior to surgery. We're going to get into that. The main type of surgery we have for bladder cancer called a radical cystectomy, and I'm going to talk about this later. These are the different therapies that I will describe that we have today and that we're building upon for treatment if someone has cancer that has spread. So those are all terminology that this slide is really just to introduce you to, and I'm going to walk you through that as I walk you through kind of the life cycle of a potential patient with urothelial carcinoma. A couple of other kind of terminology and graphs to introduce you to some medical pictures that you, coming to this, if you've had a presenter use slides before, you might have seen some of these things. This has to do with a time to event type of thing. So in this case, time to death. So going out to the right, you can see months, that's time. And then this happens to be a percentage of people that are alive at a given time point. We often will use this to compare two different types of treatments. We will often quote a median. So this happens to have a median of a 3-month difference, and depending on who you are and where your perspectives are, that may seem like a lot, it may seem like a little. But we use that as a tool really to see the overall difference between these two lines. That's called a hazard ratio. So I'm not going to quiz you on any of this, but just to kind of give you an example, we use that more or less mathematically or statistically to say what's the difference between these two treatments. In this case, it's about a quarter better. So in this case, patients would be expected, however long they were expected to live without the treatment, adding the new treatment, we'd expect to add about a quarter longer. So really how much that turns out to be is life expectancy. If they're only expected to live a year, the quarter may be another 3 months. If they're expected to live 5 years, then that's expected to be more than an additional year. Same type of a scenario, but it's just a different way of looking at it. So we have this 3-month median survival. You'll see a lot of times these p-values. That's really a statistical question. Is this true, or is it just something a fluke? Is it due to chance? So the lower number that is, the less likely it is going to be due to chance. But looking at this particular, this has to actually do with surgery, taking a kidney or not in this particular case. But basically, even though that was only about a 3-month difference at the kind of average or median, it basically is any chance of being alive at 5 years or no chance of being alive at 5 years. And that is more the way we want to say, do we want to maximize this person's chance of being alive 5 years down the line? Or maybe it's not going to be worth it for the individual. So that's more of how we look at it than just a simple number, 3-month long. Okay, that's terminology, and you'll see some of those types of curves. So urothelial carcinoma, as I mentioned before, most often would occur in the bladder, but also can occur in the tubes or ureters, as well as the inside of the kidney. Most of us, when we look at numbers, we'll look at data from the American Cancer Society, and that's just the organ where it happens. So when it happens in the lining of the kidney, that's lumped in with kidney cancer, which is different, so we don't know the exact numbers, but you can see pretty clearly that the majority of patients that get this type of cancer, it does happen in the bladder. And you can see the relative difference in terms of number of diagnoses at the top versus number of deaths. And to put that into a bigger perspective, when I talk to some of our fellows, I'll say kind of in the overall cancer world at the top versus my world, which is GU or genitourinary cancers that are down here. You can see in the red outline, cancers of the urothelium are going to be something like probably 85,000 or something like that as an estimate. With all those, we expect 18,000 or so deaths in 2017. And you can put that in perspective versus some of these other cancers. I think many of you will know that, for instance, lung cancer, the number of deaths, if we add up the 3 other most common cancers, it doesn't equate to the number of deaths. So if you add up breast, colorectal, and prostate cancer number of deaths, it doesn't equate to just lung cancer deaths, so that's just something that we continue to work on. So risk, I have a number of different things up here, but like many cancers, this is a cancer that the risk of being diagnosed does increase with age to a certain point and then starts coming down. So this is mostly going to be diagnosed in someone's 60s. We see it early, we see it later, but 60s, 70s is kind of a common age. Smoking is clearly, prior smoking is clearly the most identifiable risk factor in most patients. That could be secondhand smoke as well. And just the longer the exposure, the higher the risk. There's a number of other things that are up there. I'm just going to point out one of them, and it has to do with fluid intake. One of the reasons that a lot of these things that you'll see here, whether it's smoking or whether it's taking in or exposure to different things, the body filters out some bad things, partly in the liver and partly in the kidneys. And if something sits in the kidney for a long time, you can imagine it gets exposed there. So just by drinking more, almost anything, but we think water is going to be good, it flushes out the system, and overall, in a lifetime, there's less bladder cancer. So now to talk about the individual disease states and what we would do in terms of testing as well as treatment. So hematuria, that's called blood, that's a medical term for blood in the urine, is the number one most common presenting factor. So a patient says, hey doc, I got some blood in my urine, we do a bunch of tests, and that is the most common symptom that leads to a diagnosis of cancer in the urinary tracts, whether it's in the bladder, the kidney, or the tubes called the ureters. Other voiding symptoms or pain where those organs are, in the flank of the kidney, in the pelvis for the bladder, those are going to be the most common presenting symptoms. So what do? One thing to know is if you see red in your urine, it is very unlikely to be cancer. That being said, if we're thinking about cancer, what's the workup? So we always will start with urinary tests. And sometimes we forget this. I think it was last year, a friend of mine called me up and said, hey, I got blood in my urine. And I said, well, he's a doctor. I said, do a test to make sure it's blood. And he said, oh yeah, I had a lot of beets last night. And it turned out it wasn't blood. So other things can make the urine look red. So one of the first tests to see, is it blood or not? And then some of the other things, is it an infection? We do other, sometimes blood tests also. Is it coming from the inside of the kidney itself versus the lining? Those types of blood tests as kind of the initial screening. If it is suspicious for cancer, so there's other symptoms, or it's someone that's 70 years old that smoked for 50 years, will have a high level of suspicion. Sometimes we'll then do some more specific tests for cancer that are in the urine. We will, a lot of times, if it does turn out to be blood, do some sort of a scan, not necessarily thinking it's cancer, but one of the more common reasons for blood in the urine is a stone. So we're checking to see, is there a kidney stone or a stone somewhere else? Also, it might pick up a tumor, so that's the other reason that will be there. And if we see something, or it's a person that we're kind of suspicious for that doesn't, in the initial workup, have an explanation, we'll take a look. So the cystoscopy, looking into the bladder, and sometimes higher up, depending on what's there. This can be an office procedure, and during that procedure, especially in the bladder itself, we can do initial biopsy, as well as those other urinary tests, which are up here if it gets that far. That's the generality of someone who has blood in the urine or other suspicion. If you remember those different boxes, there is the box where it is just on the very surface or only invading a little bit. That's what we call non-muscle invasive bladder cancer. It used to be referred to as superficial, but actually a lot of these will invade the initial layer, just not very deep. So we now call that non-muscle invasive, and sometimes you see NMIBC in medical jargon. We generally will look to cure this by doing surgery with the camera. So go in, little more than we generally can do in the office, be in the operating room with anesthesia, but go in and spend some time to scrape out as much as we can beyond the tumor to get to the next layer. That can lead to a diagnosis and staging, how deep is it going, but also can be curative. That is one of the main parts of curative therapy, in addition to give it as staging or prognosis information. you'll see intravesical something. So we can put chemo into the bladder, so that's intravesical chemotherapy, or we can put immunotherapy, what we generally use as BCG, into the bladder. So that is generally done after the TURB, or scraping out via the scope, and that can increase the cure rate of just the scraping alone. Following that, to make sure it doesn't come back, there is fairly frequently urine tests as well as looking in and sometimes scans. So, some people will look at this and say it's the most expensive cancer, in part because we've got to keep doing this over time. We're working on tests that may make it so we don't have to do so many scopes, or scopes that are more sensitive using different types of light. There are all sorts of newer technologies that we can use, but overall these are the basics. Sometimes that can eventually lead to further invasion into the bladder, into the muscle. Sometimes walking in the door, it'll already be that deep. So muscle invasive bladder cancer, one of the distinctions that I didn't show on that cutout, a lot of the major blood vessels are in the muscle layer. So we worry about that cancer into the muscle layer because it might start traveling elsewhere. So that's the distinction for muscle invasive bladder cancer. We will always start off with this transurethral resection. That's the only way we can actually check the muscle. If that is higher up, and I'm going to get to that I think on the next slide, it's going up into what I refer to as the uroscopy. Generally speaking, the most common therapy in the United States and around the world is surgically based, but we know that we can improve the overall cure rates by starting with chemotherapy into the veins, so we call it systemic chemotherapy, goes everywhere, including into the bladder, and then we do surgery. In the case of when it's in the bladder, we generally do something called a radical cystectomy, so that's right here, where we remove the bladder, the whole bladder, organs are around it, and those organs are different, whether it's a man or a woman. We generally take out all the lymph nodes that are somewhere around that, and then we do what's called the urinary diversion. So the kidneys are still going to make urine, the tubes, where's it going to go if there's no bladder? Sometimes we can create a new bladder. So it's just usually taking a piece of intestine and creating a bladder, and with training overall, then people might be able to urinate down the line similar to how they were doing it before. Sometimes we create what's called a reservoir. So it's to collect the urine, but it sits there and then it needs to come out somewhere. So usually we'll create a stoma or a hole, a lot of times to the belly button. So every once in a while, sticking a catheter into the belly button to drain that urine. Other times, many of you may have heard of a colostomy, that's the colon draining out stool. We can do the same thing with urine. We're just constantly draining to the bladder and into a bag, and every once in a while that person then drains the bag. So those are different ways that we can, what's called the urinary diversion, since the bladder is no longer there. There is therapy that we can use to cure some patients with bladder cancer that a lot of people refer to as trimodality therapy. I might describe it, you'll understand that. Some people refer to that as organ preservation or bladder sparing therapy. It still starts off with going to the OR and having surgery with that, as much as scraping to get it out with the transurethral resection. But then it's followed by a combination of chemotherapy and radiation. In a selected patient population that has the tumor in the right place that can be fully resected, the cure rates are basically the same as with surgery, but it's only a minority of the patients that are actually candidates for that. What we tend to do is the chemotherapy and radiation at least part way, and it should be gone about 2/3 through therapy. If it's not gone, then we take out the bladder. So not everyone gets to keep the bladder, but some do. So that is a treatment modality for some of the patients. Once we have the bladder that's out, we put people in different groups. Was it all inside the bladder? Did some kind of stick out? That's that second line called extravesical. Or did some already spread to the lymph nodes? Now those lymph nodes are no longer in the body, so it's all the way out, but it was outside of that. And you can see there's pretty clearly 3 different groups that the cure rates are lower with each one. Each line, we can raise that cure rate by adding in chemotherapy, usually before. The other thing you'll notice is that there is a line, a flattening for every single one. So even though it's lower for those that have involved lymph nodes, it's still flat, meaning some are still cured. Meaning after initial period where patients that might have recurrence or not, there is a true cure rate, even if it's in the lymph nodes. The upper tract is a little bit different for a couple of reasons. One is it's harder for the urologist to put in a scope down here, go all the way up into this tube, and then try and take out, or somewhere along the way, to take out a big piece of the tumor. Another is that I talked about intravesical therapy. That is essentially put in a catheter, put in medicine here. It's hard to get medicine to stay up here, so we can put in a catheter and put some medicine into here and clamp this off temporarily, but it's hard to get medicine to kind of stay in that area. So it's a little bit of a different type of a disease in that sense, but otherwise we can still do our best to do scraping. We can try to put in some medicine sometimes. If someone has more invasive disease, the concept is still the same, where most of us would recommend, based upon the best available evidence, initial chemotherapy and then surgery. The surgery is a little bit different. It was called a nephroureterectomy. See if you all can say that at the end of the talk. It basically is no matter where the tumor is, it's occasionally we can cut out a little here, but pretty much no matter what it is, we take that out, the whole side, including of where it comes in the bladder, and then the person just lives with one kidney, and that's fine as a general rule. When someone has two good kidneys, we only need one, and you may have known people that have donated a kidney, for instance. So that's an overall rule. One thing I didn't mention with the chemotherapy, the main reason for chemotherapy, whether it's before or after surgery, it's not so much to shrink the tumor that's in the bladder, in the kidney, or anywhere else. It's to get rid of any cell that might be somewhere else. So the concept is basically the same for almost every solid tumor cancer we have, or solid organ cancer, meaning breast cancer, colon cancer, lung cancer, etc. The paradigm is surgery is often a main part of the curative therapy, with some sort of systemic therapy, neoadjuvant is before, adjuvant is after, and it's to essentially mop up anything that is not there. So it's great if things go, melt away. We see that as a sign that that tumor happens to be very sensitive to that. But it's not so much that main tumor, because we can take that out with a knife. It's to get the cells that are elsewhere. Okay. Unfortunately, some people walk in the door with cancer that's already spread, or will have their bladder out or whatever type of surgery, and then develop advanced or metastatic disease. So some of the symptoms are based on where the tumor is. So it might be in bone, it might be in lung, it might be in liver. Those are some of the more common areas, and there might be symptoms from that. So if I happen to have it in my bone in this finger, I might have pain in this finger. It's not that common, but those are some symptoms. It also might have to do with what we call paraneoplastic symptoms. It just means cancer in the body in one location that's causing something else, a problem in another location. So that's where some of these other general symptoms, fatigue, blood clots, those might happen. The mainstay of therapy, really since the 90s, for cancer that is spread is what we throw in a class called platinum-based chemotherapy. So the single drug that we know over and over and over again, when we look at different studies, called cisplatin or cisplatinum, as long as we combine drugs with that, we see the best results. Results meaning the most tumor shrinkage, as well as longer survival. One thing that is a little bit different in urothelial carcinoma from other cancers is that there is a cure rate. Even when someone walks in the door with cancer that's spread, most cancers, we try and improve survival. We actually, with chemotherapy, can cure some patients with urothelial cancer that's spread. So it's a little bit different than lung cancers, a lot of other cancers that are out there. Now that being said, not everyone can receive cisplatin. There's a number of factors, most commonly the function of the kidneys, because that's the way that the drug goes out of the body. So if someone's kidneys aren't working well, we might not be able to safely give that drug. Luckily, and I'm going to show you in a little bit, for the last 2 years, we've had additional therapy, and that is in the form of immune therapy that I'm going to talk about. So a curve that I talked about before, and like with the surgical curves that I showed you, this is flat out here. So even though everyone that walked in the door on this is one particular clinical trial, all the cisplatin combination chemotherapy trials showed them something very similar, 10, 15%, something like that. Down the line, even though they walked in the door with cancer that has spread, walk out of the door after chemotherapy with no cancer and they're alive past 5 years, that we would often equate to a cure. So that's a little bit different than other types of cancers. So this is a little bit of a complicated slide that I use to give talks to physicians. The main thing I just want to point out is that we have had good therapy for this box, and this box. That's what I talked about so far. If someone was not cured with cisplatin-based chemotherapy for metastatic disease, we had close to nothing beyond that, where 10% or so, or less than 1 in 10, might have significant tumor shrinkage with additional chemotherapy. So it didn't work so far. But this top pre-2016, we do have, as I mentioned, immunotherapy. So this is not unique to urothelial cancer, but urothelial cancer as amongst the best responses for the common cancers. And that's by targeting what we call immune checkpoints. So you can see you can read at the bottom, but our immune system has natural breaks. So you might have heard of autoimmune diseases. Lupus is one, there's other things that are there, where it's our own immune system attacking the body. We don't want that to happen. So we don't want to have infections or cancer or other bad things to happen, but we don't want our immune system being too strong, so it has built in what we call checkpoints. So our own immune system doesn't attack us. Cancer has been able to exploit these checkpoints and say, to trick the body, I'm not natural, but I'm your own body part, don't attack me. We now have drugs that we can block these breaks, basically, so double negative, and that can lead to responses. So actually, amongst all the different cancers, urothelial carcinoma is the one that has the most approved drugs. We have 5, and they're all very complicated long names, another challenge for people to pronounce. But we have 5 approved drugs for these patients, mostly who cisplatin didn't work for, but sometimes when they're not eligible for cisplatin. And some of these drugs can work in patients that have cancer throughout their body, and then it's gone, and can stay gone for a very long time. Also, there might not be as many side effects as chemotherapy, and head-to-head trials show that. That being said, good and bad, the immune system can be extraordinarily powerful. It can totally get rid of cancer, but it can then start attacking the body. These are here for a reason, so they're mild side effects relatively commonly, but major side effects, including death, occasionally happen. So that's how I counsel my patients is, tell me anything that you think is abnormal, just call us. Much of the time, I'm not worried, but some of the time, we need to bring them in right away. So for instance, having a little bit of diarrhea, maybe not that big a deal. It may probably happen to everyone in the room at some point in your life. When people are on this therapy, it can lead to death fairly quickly. Luckily, there is an antidote for most of these patients, as long as we catch it early enough. So we have surgery, chemotherapy, immunotherapy, but we're still not curing everyone. So now what? It's a generic slide that I have that I've used for other types of cancers, prostate cancer, etc. But now that we have some drugs, can we add to them? Can we combine them? Can we use them in additional situations? What about new drugs? And can we learn things with what I would term molecular medicine or precision medicine? That's what I get into next. So you've seen the same type of thing. We initially learned that cisplatin-based combinations in this box were able to cure some people, but not the majority. We'd use it here, cures a lot more. We're now doing the same thing with those 5 drugs for immunotherapy. We're now looking at those in addition to surgery. So not only can we just make someone live longer and make maybe their cancer go away once it's metastatic, can we combine it with surgery to increase the cure rate? We think so, but we don't know. So we're testing that. How do we make improvements in medicine? Mostly through research. So I don't know if you realize this. If you were an infant or a kid diagnosed with cancer in the United States, it's almost unheard of to get treated except on an experimental or clinical trial. 95%, 97%, depending on the data. If you're an adult, 1 in 20, something like that, 3 to 5% overall. This was a study, if I remember right, from Minnesota, so they actually did not too bad because they're at between, 3% for prostate cancer, but other common cancers around 10%. That being said, it's still 90% that didn't enter a clinical trial. Those that did, they asked questionnaires, those that happened to be on the clinical trial, those that were not, just were more satisfied with their care. When asked why, this is on us, meaning the doctors. The number one reason why patients did not go on a clinical trial, because they weren't told, or at least they didn't remember being told that it was even an option. There are other reasons, and not everyone is a candidate, but we need to know, in the doctor point of view, that a lot of this on us. Those of you that either have cancer or know someone with cancer, you should ask. So how can we, the group here, make progress? So the way I see it, it's through awareness and advocacy, as well as funding. So awareness and advocacy, I mean that, that could be on a lobbying level, or it could be doctor or family and patient interactions to say, is there anything else? Is there a clinical trial? What else can we do? And sometimes getting a second opinion. Those types of different things, I think, can make advances for an individual person as well as for society. For most solid organ cancers, including urothelial or bladder cancer, there are 3 main types of physicians that will treat: surgery, radiation, medical oncology, chemotherapy, immunotherapy, etc. I believe that this works best as a treatment team. We might refer to this as a multidisciplinary team. I think even better if we get additional members of a team, primary care, as well as the other elements of an overall healthcare team. And probably even better if we have family, clergy, throw in the dog. I happen to be a dog person, but any pet, I guess even a goldfish. I think all the more, the better. This helps support overall patients, and I think we'll get better outcomes that way. I kind of showed you the different boxes. That's the kind of the dogma you read in a textbook. Obviously, not every single patient is the same. Not every single tumor is the same. So some people will hear precision medicine as a term. Some will hear personalized medicine as a term. But really, the right treatment for the right patient at the right time is what we're talking about. We believe in cancer that a lot of this is by doing tests of the patient and or the tumor. Here, we're lucky enough to have the England Institute for Precision Medicine, and this is more or less how it happens. There's the physician and patient. We order a test that is typically a series of blood tests and or a tumor biopsy. We go through a long process looking mostly at the genes that are in the tumor, and then back to the doctor comes a report, and that report will say what's going on in the tumor that may be different than the other 50% or 99% of people with the same type of a cancer. There are ways to do this in the very broad sense. We call it whole exome or RNA-seq. We're looking at essentially 22,000 genes, or we can look at it as a single gene or a panel of 50 to a couple hundred genes. It really depends on what we want to get out of it. But we are able to today, order these tests, get them back, and have them change how we look at the individual patient. How has it related to urothelial carcinoma? So this is some older data that before we had the ability to look at every single gene in an individual tumor, we could look at some. And this is not what we want to see, but we know there's two different general paths that tumors can get to this invasive type that might then spread. One type that involves certain genes that starts in this quote superficial type that then goes there, or some that just start like that. And we just know that they're different. And we've known that for a while now, and we knew that a little bit for prognosis, but now we have something we can do about it. TCGA, so it's called the Cancer Genome Atlas Project, has been a number of different studies to look at a number of different types of cancers, including bladder cancer. And these are the initial major results where we've learned that different genes are important and have been able to put different tumors in different groups or clusters that we know might carry different prognoses and respond differently to different tumor types. We here have kind of taken the next step to look at not only tumors that may have started in the bladder, but also differences between what was in the bladder and their tumor after chemotherapy and after it spread. And we know that overall, about a third of things are the same. About a third of things are only in the bladder, and about a third of things are only after chemotherapy and spread. And it's likely that the things that are happening more in the tumor that is spread, because we know that's what leads to problems, is going to be more relevant. So we know that we can't necessarily only look at that biopsy from 10 years ago. Sometimes we need to do another biopsy. And let's see if I can get this to work.
And it's having an impact on patients in and out of the hospital.
Fox 5 Jack Crowley shows us how it works in tonight's Big Idea.
You're looking forward to a long life, I hope?
Maybe about 100.
77-year-old prostate cancer patient Alex Sarmiento has good reason to feel optimistic about his future. 3 years ago, Alex was diagnosed with prostate cancer, and the disease had spread to other parts of his body.
I asked Dr. Bladder, should I retire? Because if your husband is dying, enjoy the last years of your life together. I said, no, don't retire, don't retire.
At first, Alex's condition with treatment remained stable, but in April, after a trip to visit family in the Philippines, his health rapidly declined.
I was weak and exhausted. I thought it was a deadlock.
Alex's wife says her husband was twice put in the hospital and given debilitating rounds of chemotherapy.
When you have cancer, there's really no relief.
Instead of getting better, Alex was getting weaker. Dr. David Nanas is the chief of hematology and medical oncology at NewYork-Presbyterian. He decided to give Alex a liquid biopsy. This diagnostic test, with the help of technology, is being used in new, innovative ways. Dr. Scott Tagawa is an oncologist at NewYork-Presbyterian.
If someone develops what we call advanced cancer, or some people would call it metastatic cancer, that is individual cells from the tumor breaking off and landing somewhere else. And that is in general, if someone is going to die of cancer, that is usually why. As those cells travel around in the blood, we can capture them in a test tube. We could then take those individual cells from the test tube and analyze them.
The test is relatively non-invasive. In the past, in order to get tumor cells from a patient, a doctor had to do surgery or a biopsy. Now a nurse draws blood from the arm like what happens in a routine blood test. The blood sample is taken to a lab in the hospital. That sample is put into a machine called a cell selector. Using the cell selector, the lab technician can isolate cancer cells from healthy blood cells. Images of the cancerous cells are then projected on a computer screen to be studied by the doctor. The pictures can reveal what kind of tumor it is, the DNA of the tumor, and if the cancerous tumor is becoming resistant to a drug. The results of the liquid biopsy help doctors customize a treatment for the patient because it can determine the type of the tumor a patient has and what medicine will work best in treating it.
What it also allows us to do is to figure out why a certain patient's tumor is becoming more resistant and get ahead of that.
Some doctors say the liquid biopsy has revolutionized oncology. The results allow doctors to track the progression of the disease in real time. You could have a liquid biopsy every day, essentially removing the guesswork and allowing doctors to prescribe the right treatment.
It was a quick turnaround time that I got this result almost within a week, whereas sequencing the tumor sometimes can take a little bit longer. And it informed me that he had a BRCA, mutation.
Just a few months into his new treatment, Alex's health dramatically improved.
He was getting much, much better.
As a doctor, is that satisfying?
Very satisfying, very satisfying. So I said, and the liquid biopsy really helped me quickly make a treatment decision, get him a drug that was very effective, but not a whole lot of toxicity. He's doing very well.
You feel better?
Yes. Instead of having a sick spouse with you, have somebody that we do everything basically, like what we did before.
Sharon Crowley, Fox 5 News.
And head to our YouTube page to see other big idea reports from our Fox 5 team.
Making good progress.
Yeah.
All right.
So we are using these liquid biopsies really today in combination with tumor biopsies because they complement each other. We can do different sorts of tests. They do help us determine prognosis to some extent, and that can be helpful for counseling, but probably even more importantly, they can help us direct therapy. So this is just a schema of a few genes that we can potentially target. This is the surface of the cell. Sometimes there's things on the outside of the cell that we can hit, and sometimes we can hit internal process. I would term that overall targeted therapy, and what do I mean by that? So I gave a talk on bladder cancer last month to the Cuban Urologic Association in Havana, and this is a slide I used to let them know my viewpoint, my opinion of what I think that is coming out in the next 1 to 2 years of new drugs that we'll have at our disposal to help patients with the urothelial bladder cancer. You don't necessarily need to know the details, but they're all targeted therapy. So what is targeted therapy? So one thing that we can do is we can take, maybe not. Let's see if, all right. So I'll explain it to you. So one thing that we can do is we can figure out what is going on in an individual's cancer cells. So that will be the target. So some of the time, they will have what I like to term, as you can see here, a certain lock. This is a cancer cell that's there, this is a non-cancer cell that's not there. We can infuse a certain key, usually that's with a monoclonal antibody, but something will recognize only those types of cells, so it'll take chemo, it'll take radiation only to those cells. Some of the times, it is an internal process that I mentioned, so we take a pill and it will get to all the cells, but it will only really damage those cells that have a process that is driven by what we call a certain pathway. So that's what we call it it's targeted therapy. So overall, what we've learned over the last really short number of years is taking advances that we've started off in the lab and brought into the patients and taken information from patients back to the lab and then back and forth, we have seen not just information that has led to grants or publications or anything else. Luckily, we've seen major differences from diagnosis to treatment. Patients are feeling better, getting cured more often, and living longer today compared to in the past. We're not stopping, but we're happy to continue on. I mentioned this before. I don't know if any of you know someone with bladder cancer or have bladder cancer. Probably the most important message for you or for them is, yes, there are these boxes, but live your life. Hopefully you're cured. Continue to live your life. Get your checkups. If you're not cured, take the therapy. Hopefully it'll shrink things, make you feel better, and live your life. So I showed you a number of different medical, clinical, and research advances. I certainly do not do that alone. So I work with a huge team of people, both on the clinical side as well as on the research side. But I'll stop here and see if you have any questions.